located within the wall of the right atrium. The sinoatrial node pacemaker normally governs all the rhythm in atria and ventricles. The normal rhythm is very regular with minimal cyclical fluctuation. And atrial contraction is always followed by ventricular contraction of the normal heart. When the rhythm becomes irregular, either too fast or too slow, the frequency of the atrial and ventricular beats are different. This is called the arrhythmia. The term dysrhythmia is used. The most common disorders are atrial fibrillation and flutter. The incidence is highly related to the age and presence of the underlying heart disease. Okay, bradycardia is defined as the rhythm disorder with the heart rate less than 60. And the tachycardia is rhythm disorder when the heart rate more than 100. The treatment depends on the stability, hemodynamic stability of the patient, and you have to recognize the type of tachycardia and bradycardia algorithm. However, for the purpose of this lecture, I won't be talking about that due to the time constraint. Okay. So, first of all, we have to know about the normal cardiac action potentials. As you know, in heart, there are pacemaker cells and contractile cells. So, as you see on the left, it is the action potential for the pacemaker cells, and on the right side, it is the action potential for the contractile cells. Okay, so we go to the left one first. When the cardiac cells are stimulated by an impulse, their membrane permeability change, and the ions move across the membrane and hence generating action potential. So the first phase is the phase 4, which is pacemaker potential or slow depolarization. At this stage, the membrane potential in pacemaker cells start about at negative millivolt. The spontaneous influx of the sodium ion into the sodium channel opening during the phase 4. During phase 0, the threshold increased to the membrane potential increased to negative 40 and then achieve the threshold. Here, initially the voltage gated L-type channel will open and the calcium will rush in and cause rapid depolarization, causes less negative over the membrane potential. Then phase 3, the calcium gated channel start to close and the potassium gated channel will open and will cause the efflux of the calcium, the potassium, hence cause repolarization. Okay, as on the right side, for the contractile cells, the resting membrane potential is more negative, which is at negative 90 millivolt. This is called phase 4, which is resting membrane potential. During phase 0, there is initial rapid depolarization. The voltage gated sodium channel will open and sodium will rush into the cell. Here, the L-type calcium channel start to open again, but increase slowly. During phase 1, also known as early rapid repolarization, there is efflux of potassium, which means out of the cell. So the cell will become less positive. In phase 2, there is prolonged plateau phase, which means at this time, there are movement of the calcium into the cell and potassium outside the cell. Hence, it causes plateau state. During phase 3, also known as rapid repolarization, there is gradual inactivation of calcium channel and continuous efflux of the potassium outside the cell, which cause cell membrane to become more negative. Then the cell achieve the resting membrane state at the phase 4. Okay. And next, just talk about the for the slide, for the picture, there is action potential and for the conducting and contractile cells. So absolute refractory period, or ARP, during this time, this period, the cell cannot be depolarized to produce another action potential, regardless of the stimulus strength during the phase 0, 1, 2, and initial part of the phase 3. However, after that, there is RRP, or relative refractory period. During this period, a stronger than normal impulse can lead to the action potential, which means after a later part of the phase 3 and 4, any stronger than normal impulse can stimulate action potential. All right, before we go into the mechanism of arrhythmia, we have to know about the normal automaticity. This is the picture of the action potential in the pacemaker node. Normal automaticity means the property of the cardiac myocytes to undergo spontaneous depolarization, initiating an electrical impulse. It consequences in the phase 4 depolarization. You can see the upsloping of the in the orange graph, upsloping in the orange color one. Okay, and the rate of automaticity will depends on 3 factors, which is rate of the phase 4 depolarization, 2, maximum negative membrane potential, 3 is threshold potential. Okay. The automaticity normally occurs within specialized pacemaker cells within the sinus atrial node, as well as other latent pacemaker in the atria, AV junction, and ventricle. Normally, the intrinsic rate of the pacemaker in the citrional node range 50 to 90 beats per minute, or in the atria 40 to 60 beats per minute. AV junction is 40 to 60 beats per minute, and the ventricle is 15 to 40 per minute. Normally, the sinoatrial node reach the action potential very fast. Then it acts as a natural pacemaker. The sinoatrial node will drive the heart rate. So when there is sinus rhythm, the other pacemakers will not go or will not express the automaticity, in which their depolarization is suppressed. So you won't see the intrinsic intrinsic rate of the pacemaker unless the sinus atrial node is not functioning. When the sinus atrial node is not functioning, any other pacemaker can become the new pacemaker of the heart. So basically, it's just a fail-safe mechanism. So when there is some block, the heart will not go into cardiac arrest, but the other pacemaker will become the natural start as new pacemaker of the heart. Right. For the mechanism of tachyarrhythmia, you have to understand about 3 factors that cause arrhythmia in the heart. First is enhanced automaticity. So, as I mentioned before, the normal automaticity, you can see from it is affected by the sympathetic and parasympathetic action on the beta-1 adrenergic receptor. So, the noradrenaline and adrenaline released by the body will affect the slope of the phase 4 in the depolarization. So, as you can see, there are 2 action potential in the graph. However, if there is a more sympathetic effect produced by the body, it will increase the slope of the phase 4 and increase the heart rate. So you can get more action potential produced. Okay, but if there is increase in parasympathetic effect via muscarinic receptor, the slope of the phase 4 depolarization will become decreases. Nampak lebih apa less steeper lah. And then then automaticity and the heart rate will decrease. So from the 2 action potential, it become 1 action potential. Okay. So here are the list of factors for the enhanced automaticity. It could be enhanced normal automaticity or abnormal enhanced automaticity. So the normal automaticity occurs within specialized pacemaker. It can be due to stimulation of sympathetic nervous system, such as sepsis, fear, pain, or hypovolemic shock, or inhibition of parasympathetic nervous system, be from the medication, disruption of the vagus nerve, and also it could be the disorder in the sodium ATPase. It can be caused by ATP depletion from the hypoxemia or ischemia, or digoxin toxicity, or hypokalemia. In the abnormal enhanced automaticity, which occurs within non-pacemaker cells, most of the most common causes are acute ischemia or reperfusion. And then it could be caused by the congestive heart failure. The second mechanism for tachyarrhythmia is re-entry. It is the majority of the tachyarrhythmia are caused by the re-entry mechanism. It occurs when electrical impulse doesn't cease at the end of one cardiac cycle, but persists and re-excite the heart as part of the self-propagating mechanism. I'm sure you guys find this quite difficult from the words, but as I can explain from the picture, so you can see the picture. There is on left side and the right side. For the left one, there is electrical impulse coming from the up go downward. You can see the black arrow. So when they are conducting into in the cardio in the heart, there are two pathways, which is slow and the fast pathway. The slow pathway, there are fast. What happened is there is fast refractory period, and the fast pathway, they have slow refractory period. So as you can see from the black arrow on the left, when it go downwards, it'll branch into the left and the right, which is into the slow and the fast pathway. However, in the slow pathway, you can see all the arrow become bengkok because of the slow conduction. And then on the right side, you can see the pathway is very smooth. And then because of the fast pathway arrive first at the bottom of the conduction, it will cancel with the slow pathway. And then the electrical impulse can be transmitted downward. This is what happened in normal cell. So you have pathway and the fast pathway. However, in the re-entry occurs when there is, you can see on the right side, there is a premature beat happen. So when there is premature beat, as I mentioned before, in the fast pathway, there is prolonged refractory period. So you can see on the right side with the black arrow, the electrical will be able to go through the slow pathway. However, it can't go into the fast pathway because after the normal action potential has been delivered previously, the fast pathway hasn't achieved still in the refractory period because of the so the electrical impulse cannot be delivered. Hence, the impulse will be blocked. And then, as the impulse move from the slow pathway, it will circulate and go upward back. At this time, the fast pathway already finish their effective refractory period. Hence, the electrical impulse will be moving in circulating. It will go upward in the circular area and also go downward. I'm sure it's quite hard to understand, but you can see the video later on. I give in the slide and the link. So here is the some video regarding the normal pathway. So as you can see again from this is normal one. The left side is the fast conduction. The right side is slow conduction. You can see the electrical impulse from the fast conduction will cancel the impulse from the slow conduction. Okay, this is the normal one. Okay, the third mechanism contribute to the arrhythmia is triggered activity. It occurs when the depolarizing oscillation of the membrane potential occurs during or after an action potential, in which the oscillation is strong enough to trigger a new action potential. This is called after depolarization. Okay, so as you can see in the picture, after depolarization can be divided into two groups, which is early and after depolarization. So for early after depolarization, the during early phase 3 and then delayed after depolarization, the impulse generated at phase 4. The difference between them in early and delay after depolarization, general mechanism in early after depolarization, it prolong action potential. However, in the delay after depolarization, there is normally it's caused by excess intracellular calcium. Common etiologies for early after depolarization is hypokalemia and prolonged QT, while for the delay after depolarization, it could be from the ischemia, increased catecholamines, and digoxin toxicity. Early after depolarization occur if you have slower heart rate, while delay after depolarization, the risk will increase at the faster heart rate. So here are mechanism of the arrhythmia. So you can increase automaticity. It could be enhanced normal automaticity or abnormal automaticity. So here are the example of the rhythm. However, I won't be discussing much because it takes some time. Probably you guys can do self-study at home. So the re-entry can be divided in we can divide the re-entry into physiology and anatomy. Here they divide into macro entry and micro entry. This is rather just a map. So here the example of the re-entry. And then the third one is you can classify based on early after depolarization or delay after the depolarization. As you can see from the example, they not some of examples are not necessarily in the same group. Like atrial tachycardia, it can be in the due to increased automaticity or trigger activity. Okay. So summary, you can I hope you guys can remember the three causes for tachyarrhythmia. First is increased normal automaticity. Second is triggered activity. The third one is re-entry. Sorry for the wordy slide. So you guys, so we proceed with the second one, anti-arrhythmic drugs. So all of the anti-arrhythmic drugs act by altering the ion fluxes within the excitable tissue in the myocardium. The three ions that are important are sodium, potassium, and calcium. The anti-arrhythmic drugs can be classified by the ability to block one or more the ions across the membranes of the excitable cardiac muscle cells. So first, I will just talk about the function of the sodium channel. The sodium channel blocker, the effect of the blockage of the channel will cause slow the rate and the amplitude of the phase 4 of depolarization. It will reduce cell excitability and reduce conduction velocity. However, sinoatrial node and AV node, relatively, they have few sodium channels. Therefore, the effect of the sodium channel blocker can be seen more in the contractile cells. Okay, second is calcium channel blocker. The L-type calcium channel are responsible for the prolonged plateau phase. The calcium current entering the cells during the phase 2 is intense and prolonged. The calcium channels are slow to be activated and slow to inactivated. The blockage of the calcium channels reduce the amplitude and length of the phase 2, which is the plateau phase, in the atrial, Purkinje, and ventricular cells. In sinoatrial node and nodal cells, calcium entry through the L-type channel represent the major ion reflux during the depolarization. Okay. The third one is potassium channel blocker. They are activated during the phase 3, which is repolarization of action potential. The blockage of the potassium prolongs the action potential duration and then cause an increased effective refractory period. So from the picture here is Vaughan Williams. He's a British cardiac pharmacologist. He produced the Vaughan Williams classification since 1970 and it's still valid until today. It says that drugs that within the class not necessarily clinically similar, but a patient may respond well to one drug in a given class but not another. And almost all of the drugs that are available today have multiple actions. So sorry, I haven't updated the slide there. Actually, there are 5 classes of the anti-arrhythmic drug. Class 1, then that's divided into class 1A, 1B, and 1C. Class 2, class 3, class 4, and class 5. The class 1 is the sodium channel blockage. Class 2 is beta blocker. The class 3 is potassium channel blocker. The class 4 is calcium channel blocker, and 5 is miscellaneous. Example for miscellaneous are atropine, Maxaf, digoxin, and adenosine. Okay. So the classification is incomplete as some drugs fit into multiple categories, such as amiodarons and sotalol. Okay. So here are the classification based on the site of action at the central alien. So you can see the beta blocker and calcium channel blocker and digoxin. It acts more on sinoatrial node. The class C calcium channel blocker and beta blocker and digoxin acts also on the AV node. Okay, and the lists are provided there. Okay, you can just read at your own time. Okay, so in terms of pneumonia, I'm sure you guys blocker B, class 2 beta blocker, class 3 is potassium channel blocker, and class 4 calcium channel blocker, and 5 is miscellaneous. So for the class 1, the class 1 sodium channel blockade will inhibit action potential prolongation by blocking active and refractory sodium channels in non-nodal cell, which is the contractile cells. Okay, as you can see in the graph over there, it will decrease the phase 0 slope, and actually it reduce the amplitude of the action potential. So in the graph it's not accurate lah. Actually you can see the at phase 0 it should be less steeper, and the amplitude it should be lower lah. Okay, so class 1 you can see on the left one, class 1A, it will prolong the AV conduction, hence prolongs the action potential. Okay, and class 1B, also known as fast dissociation lah, because it shorten the QT interval lah. Okay, and then the third one is class C, also known as slow dissociation. It has highest potency. What it will do is prolong the QRS interval. Okay, so what are the effects of the class 1 anti-arrhythmic drug on the treatment of tachyarrhythmia? It's on automaticity. It can suppress abnormal automaticity by decreasing the slope of the phase 4, which I mentioned before. So during the abnormal automaticity, the slope will increase, but with the class 1 anti-arrhythmic, it will suppress the abnormal automaticity. Mas water ya. I don't want to check. Okay. The second one, it can cause indirect vagal effect. Class 1 indirectly inhibit vagal activity. So the vagal actually supply the sinoatrial and AV node. Okay, so actually class 1 drugs, although it can reduce the rate of the effect with tachyarrhythmia by effects on automaticity, actually it can increase the rate of ventricular rate. Okay, because and because of that, because you accidentally the undesired effect is it will inhibit the vagal activity over the sinoatrial node. No, sorry, this is the picture. Okay, indirect vagal effect. You can see the drugs indirectly inhibit vagal activity, so you will increase the sinoatrial and AV node conduction. So it can increase it can cause increase the ventricular rate. That's why occasionally you require concomitant beta blocker or calcium channel blocker to slow the action in the AV node. So we proceed with the class 2. Effects, the class 2 drugs, which is the beta blocker, decrease automaticity by decreasing the slope of the phase 4 depolarization. As you can see in the picture over the right side, the original action potential in the on the left one, you can see because of the effect in beta blocker, it will reduce the slope of the phase 4 depolarization. Hence, the prolonged and also it prolonged repolarization, which decreases incident of re-entry. So as you can see the picture on the right side, the new action potential will be wider, okay, and slower in terms of the action potential. So for class 3, which is potassium channel blocker, what it does, it prolongs the phase 3 repolarization by blocking the efflux of the potassium conductance. It means it will prolong the action potential and effective refractory period. So it helps arrhythmia in treating arrhythmia by suppressing the re-entry mechanism. What it does, you can see the effect is prolonged QT interval. Okay, so example of medication are sotalol and amiodarone. Sotalol is good to treat ventricular tachycardia, atrial fibrillation, and atrial flutter, and it also has class 2 activity. While the amiodarone is good for the VT-VF used in atrial fibrillation and flutter. The side effect commonly is pulmonary fibrosis and thyroid dysfunction. However, amiodarone also has an effect, has also property of class 1, class 2, and class 4 activity. The class 4 one is calcium channel blocker. The calcium channel is found in the vascular smooth muscle, myocardiocyte, sinoatrial node, and AV node. Okay, the effect of the blocking L-type channel cell. So basically, in class 4, we focus more in the heart. The example of the drug is verapamil and deltaism. The drug slow the rise of phase 4, as you can see in the picture, the bottom, and prolong repolarization of the AV nodal node. So it is useful for the arrhythmia that caused by the re-entry. Okay, so the last one is class 5, which is miscellaneous drugs. So there are 4 important drugs that you have to remember. This is a busy slide, but I just talk about the important one. Probably it's important for the first year, for the exam and actually knowledge purpose. Actually, sorry. Okay. So first, go with the adenosine. So it's naturally occurring nucleoside composed of adenine and D-ribose. It is formed from the breakdown of ATP in the cells and used in the diagnosis and the treatment of SVT. As you can remember, the dose is 6 to 12 mg and followed by the bolus saline flush. And the peak dose is 0.1 mg per kilo and then followed by 0.2 mg per kilo if it's not reverted. Okay, so mode of action, it binds to the A1 receptor in cardiac tissue. So in the cardiac tissue, it inhibits the L-type calcium channel, so it will cause slow conduction velocity, so negative dromotropy. It in the sinoatrial node and AV node, it will reduce the pacemaker current, so reduce the firing rate, so negative chronotrophy, and inhibit the release of noradrenaline from the sympathetic nerve terminal by binding to presympathetic cholinergic receptor. Okay, it also binds to the A2 receptor in vascular smooth muscle. It causes hyperpolarization and relaxation of the smooth muscle, and it causes vasodilatation. Okay, so sorry for the busy slide. So probably you is contraindicated patient who have bronchospasm and asthma. You have to know the effect or side effect of the elicited by most of the patient when we give adenosine. You have to advise the patient about the side effect, which is flushing, chest discomfort, dyspnea. Okay. Second drugs in the class 5 is atropine. So it is used to counter bradycardia, anticholinergic, organophosphate poisoning. Okay, okay, we can proceed to the next slide. So the effect, probably the most important one, it can cause reflex bradycardia if it's used in lower dose, especially in peaks. And then you have to watch out about the toxicity lah. Okay. Your patient have urinary retention, confusion, and so on. Okay, the third one is digoxin. Okay, digoxin is used in AF, flutter, heart failure, and prevention of SVT post thoracotomy based on SASADA lah. Okay, and loading dose is not more than sorry, it's 10 to 20 mic per kilo over 6 hours, oral or IV, until you achieve desired effect. Okay, and the slow IV, the IV should be given slow, not more than 0.02 5 mic per minute, and the effect only will be seen in after 2 hours. Okay, so mechanism of action for digoxin, it has direct effect and indirect effect. So the direct effect, as you can see in the picture on the right side, the main action is to block the sodium potassium ATPase pump, which are responsible to cause to increase intracellular sodium. To reduce intracellular sodium and to increase intracellular potassium. So when you block the sodium ATPase, the sodium will be increased in the cells. Okay, it affects the sodium calcium exchangers, which located next to the sodium ATPase. So in overall, because of high sodium in the cells, the will be increase in the calcium in the cells from the effect of the influx of the calcium. So overall, you will get increased contractility, and at the same time, reduced intracellular potassium will cause the slowing of AV node. Okay. Indirect effect, the digoxin has increased vagal activity over the heart. It will reduce the sinoatrial node, hence it will reduce the heart rate and reduce the conduction velocity. So, so you have to know the sign of the digoxin toxicity lah. Okay, the side effect is in GI, nausea, vomiting, CNS, confusion, headache, drowsy, and then all the anti-arrhythmic drug can cause arrhythmia. Okay, so increased risk of the digoxin toxicity if you have hypokalemia, hypomagnesemia, or hypernatremia and hypercalcemia. Other causes that increase risk of digoxin toxicity are acid-base disturbance, hypoxemia, renal failure, concomitant drugs use. Okay. Okay. Last one is Maxaf. This is the magic drug. Okay, because it has many function, as you can see in the next slide. All the indication of to use of the magnesium, you can see 11 points lah over there for the eclampsia, hypomagnesemia, tocolytic therapy, torsa de pois, asthma, cerebral edema, spasm. Okay, so actually there are 4 important mode of action of the magnesium sulfate. First, it will reduce motor and plate sensitivity to acetylcholine and reduce neuromuscular irritability. It will block the neuronal uptake of the calcium. It will inhibit the platelet aggregation and increase the prostacyclin synthesis. Okay, as you can see in the picture over on the right side, the effects of the magnesium in the endothelial and the smooth muscle. So in the endothelial will increase, the net effect is vasodilatation and reduce platelet aggregation. This is due to increased endothelial function, releasing nitric oxide, will cause vasodilatation, and increased production of prostacyclin, which inhibit platelet aggregation. Okay. So the effect on smooth muscle will cause relaxation and decrease vascular resistance due to the effect of the reduced calcium activity. Okay. So as mentioned before, probably you can read it at your own time. So there, you have to watch out for the MedSaf toxicity. Can be flushing, headache, dizziness, arrhythmia, weakness or cardiac arrest. So normally the mnemonic that we remember, especially when patient we give the loading MedSaf for the long time. For example, in patient eclampsia or preeclampsia, because you have to load for several hours lah. Normally, what we have to do is you have to remember the verb lah, mnemonic. Hypotensive, which is the BP low, urinary retention. So you have to insert CBD and measure the urine output. Okay. R is respiratory depression. P is patellar reflex, which is decreased or absent. Okay, there are the dose. So for the treatment in specific disease. Okay. So sorry for the 90 slide lah. So basically, I hope you guys can remember the mechanism of the tachyarrhythmia and the classification of the medication in the Vaughan-Williams classification lah. Okay, that's all from me. Thank you for your attention. So you have any question? We have Anum here and all the registrars lah in the Alpha group. Or if we have any supervisor or specialist. So basically kalau macam slow conduction tu ibaratnya kita lalu jalan yang apa dia bagi analogi bumpy tapi ada water. Kalau fast conduction flat tapi dusty. So kalau passion fast conduction kita bawa laju kereta tapi debu tu akan terbang, so refractory phase lama. So input tak boleh masuk lah. So that's why kalau patient yang bumpy road tu dia slow tapi dia tenang balik cepat je. So yes lama. That's why bila next premature ectopic datang, dia pergi dua-dua tapi dekat fast tu dia dah block sebab dia still refractory period. By the time dia nak pusing balik tu dah refractory period habis dah. So that's why dia pusing. Tu je lah, tapi nantilah video bagi link dah tu.
Alright guys, we proceed with the approach to palpitation in A&E. So approaching a patient with palpitation actually in some way is easier if we compare with other symptoms because relatively the differential diagnosis or any possible diagnosis of palpitation is short. But in some way, it is actually difficult because at the time patient already arrived in ED, the symptom already relieved. So unless the patient is experiencing palpitation at the time of our assessment, we will be unable to make the diagnosis at the time of presentation. And then I'm sure that palpitation, we have encountered many cases in our casualty, and I know that we all can manage very well palpitation. All right. So this is my slides, approach to palpitation. So this is my outlines. Actually, I have about 55 slides, but it's quite lengthy and also wordy. But this is just a repetition because I'm sure that all of you already know the proper approach of the palpitation. All right. I found a few definition regarding palpitation from few reference, but most of them looks like similar each other. So first one is I referred to uptodate.com. Palpitation described as a noticeable heartbeat that may be concerning to the patient, either too fast, irregular, or too strong. Other definition from Oxford Concise Medical Dictionary, it describes palpitation is an awareness of the heartbeat. And then from the differential diagnosis Churchill Pocketbook, it mentioned that palpitation is awareness of heartbeat. Although benign in the vast majority, palpitation are occasionally a manifestation of a life-threatening disorder. All right, I'll show you a case. A 32-year-old female patient presented to casualty with complaint of palpitation and exercise intolerance for the past 6 months. Palpitation were intermittent and irregular and lasted 4 hours. For 6 hours actually, for 6 hours. So we started, we start the discussion from the triaging the patient, and then take the vital sign, focus history, and proceed with the clinical examination and also investigation. Actually, this is a case, and it is an interesting case which is reported in 2016, and I'll show you in the last slide what is the final diagnosis of this case. It's a very interesting case. All right, for the history, she has had NYHA class 1 dyspnea on excision for the past 6 months. She had very active and was previously able to run a marathon. So basically, she is active in sport. There was no history of syncope or chest pain. She has no other chronic medical problem and had no prior cardiac history. And she did not smoke or use illicit drugs, and there was no family history of sudden cardiac arrest. So please remember this case. I will repeat again in the last slide. All right. So approach to any case, start with the history taking. So what are the history item that we should ask the patient? Focus history. We try to analyze further about the palpitation. What is the duration and timing of the palpitation? Is this something that just started, or has it been happening for many years? For example, how frequent are the episodes of the palpitation? How long do they last? And then, is the patient experiencing palpitation at this moment? This is the important one. At the time you encounter any patient in any zone, even you can find any patient even triage to green zone with palpitation only. So ask him or her the description of the palpitation. Is it described as fluttering, pounding, or skipping a beat? All right. Next is, what are the specific triggers, or what are the causes of that symptom? Whether during the exercise, standing up too quickly, for example, or use any specific medication prior to the symptom, or any excessive caffeine intake, smoking, and alcohol intake. Next is quality or regularity of palpitation, whether it's too fast or maybe it's irregular or too strong, or maybe patient can have all those quality of the palpitation. And then next, what are the associated symptoms? maybe palpitation is the chief complaint, but what are those other associated symptoms? For example, dyspnea, maybe some degree of dizziness, episode of syncope, chest pain, anxiety, profuse sweating, reduced effort tolerance, and altered mental state. All right, and then further history, we can ask regarding the risk of cardiovascular disease. Maybe patient have previous diagnosis of IHD, hypertensive heart disease, heart failure, heart valve disease. So we can expect the origin of the or the causes of the palpitation may be from the cardiac cause. So next is history of recent alcohol or illicit drug use, family history of early sudden death. Recent life stressor may be suggestive for panic disorder or panic attack, or maybe anxiety disorder. So we proceed with the physical examination. Generally, we can start with the GCS, or maybe the conscious level of the patient and hemodynamic status. Vital sign. In patient with postural orthostatic tachycardia syndrome, patient will have a significant difference in vital sign in different position, lying, standing, sitting, and so on. And then determine the heart rate and rhythm, the pulse volume, and also don't forget to record the temperature of the patient, because possibility to have tachycardia because of every rise in temperature. So generally, the heart rate increases about 10 beats per minute for every rise of 1 degree Celsius in temperature. So if we try to correlate the heart rate and also the temperature of the patient, disproportionate increases in heart rate should prompt a search for other causes. So next, respiratory examination, cardiac examination, and also don't forget to ask regarding the thyroid symptom, and also proceed with the thyroid examination, because if history is consistent with the hyperthyroid symptom, perhaps patient may have the diagnosis of hyperthyroidism. Look for enlargement or any tenderness or nodule that could be associated and cause the hyperthyroidism. All right. So what are the investigation? All palpitation patient came to our casualty, a warrant for ECG. So all patients should get ECG at time of initial presentation, even if arrhythmia is not currently present. Patient came to our casualty with palpitation, but at that time, when patient arrived at triage, he or she may claim that currently he or she already have no any symptom or appear well, but still we have to do the ECG, and then we can proceed to blood investigation, FBC, electrolyte, renal function, liver function test, glucose level, because hypoglycemia also can cause palpitation. And don't forget, if the history suggestive for hyperthyroidism, we can send for TFT, cardiac biomarkers, and also urine toxicology, according to, I mean, the case basis lah, case basis, and echocardiogram, and also chest radiography. So this is the algorithm I got from internet. So from ECG finding, I'm not going to discuss very detail in the how to interpret ECG, but from this algorithm, we can divide into sinus tachycardia and also other arrhythmia. Basically, if a patient have ECG with sinus tachycardia, if the vital sign is normal, maybe BP normal or elevated, history and examination itself actually can give the idea what are the causes of the palpitation. But if patient has sinus tachycardia but BP compensatory response for hypotension. So we have to work up what are the causes of the hypotension. Maybe patient have losses from GI, maybe some hemorrhage, something related to the hypovolemic. Alright, so from other arrhythmia, patient may have bradyarrhythmia and also tachyarrhythmia. But usually bradyarrhythmia, patient will come with the symptom of maybe syncope, maybe dizziness, and so on. So we have to work up appropriately. And then if the ECG show that it's very fast rhythm, so we can identify what are the exact rhythm that patient have. So we can start with few maneuvers, Basava maneuvers or vagal maneuvers, carotid massage, and if not respond to the maneuvers, we can proceed with the medication. For example, adenosine. So later I will discuss details. Next. So this algorithm I copied from our textbook, Shelley Oy, Universal Algorithm. So basically, we approach when we encounter a patient with tachycardia, try to check for any serious symptom and sign. All right, again, we can start give oxygen if needed, IV access, put on cardiac monitor, and do an ECG. And then, if patient has a serious symptom and sign, we can proceed with the synchronous cardioversion. But if patient is stable, try to detect what are the type of ECG that patient have at the moment, whether narrow complex tachyarrhythmia or wide complex tachyarrhythmia. So please remember this: sinus tachycardia should not be cardioverted. So we have to clearly detect the ECG rhythm. So sinus tachycardia is okay. So please remember this lah. Alright, I will repeat this again in next few slide. So what are the rhythm under narrow complex? Regular, we divide into regular and irregular. Those are the rhythm possible under the regular narrow complex. Sinus tachycardia, SVT, atrial flutter with regular AV conduction. Secondly, if irregular narrow complex, perhaps patient will AF, atrial flutter with variable block, or MAT, multifocal atrial tachycardia. Alright, this algorithm I also copy from the Shelley Earl. We can assess ABC, responsiveness, obtain history, physical examination, and so on, and then analyze the rhythm. Alright, if regular, normal, complex tachycardia with pulse, we will differentiate whether patient is unstable or stable. If unstable, we just proceed with the electrical treatment, which is synchronous cardioversion. And then in stable patient, we can start with the drug first: adenosine, verapamil, and diltiazem. If not respond to any chemical medication, we can proceed with the electrical treatment. So this is just the repetition. So these are the sign and symptom, whether to the differentiate patient stable or not. If patient develop chest pain, breathlessness, or mental state, or maybe hypotensive, SBP less than 90, clinical features of shock or clinical features of heart failure, so we can say that patient is unstable. And then we can proceed with the synchronized cardioversion. So regarding the management, So I just repeat on some medication that we have discussed in first presentation by Dr. Bukhari. So first is SVT. Actually, in stated in Shirley Oy, the first line should be the first line of treatment of SVT is a non-pharmacological method, which is vagal maneuvers. So we have Valsalva maneuvers and carotid sinus massage. I don't have the video that I can provide to you, but you can see detail how do we perform the vagal maneuvers in Shirley Oy textbook, and also we can just Google or YouTube lah in internet. So if the maneuvers unsuccessful, we can proceed with the adenosine verapamil and diltiazem. And next we can start synchronized electrical cardioversion if the medical treatment is failed or patient unstable. So these are the doses of adenosine, verapamil, and diltiazem. All right. This is a very important message here. Before attempting chemical cardioversion, beware of the rhythm. Maybe we first notice SVT, but actually patient have AF with Wolff-Parkinson-White syndrome. So how can we differentiate both of these? We have to see the QRS complex. If SVT, QRS should be monomorphic, but AF with WPW syndrome, the QRS complex will exhibit multiple morphologies. Why? Because if AF with WPW syndrome, it's contraindicated to start this chemical cardioversion. Alright, in AF and atrial flutter, I referred to Shirley Oy textbook. Actually, the aim of the treatment is ventricular rate control. Actually, the clearly defined target heart rate is not available in the textbook, but reasonable level that we aim is around 100 to 110 beat per minute or less. All right. The aim is the rhythm control in AF aims to return the patient to sinus rhythm. So these are the drugs that we can use. We can start in patient with AF or atrial flutter. Different in patient with no heart failure, and also if patient has the heart failure symptom. So these are the doses. I think this one all of you can study later by yourself. So the conversion of rhythm to sinus will restore organized atrial contraction, which capable of dislodging and creating an embolization of clots. So our main concern is the atrial thrombus, because patient with AF may develop the thrombus after the onset of the AF, usually around 48 hours after the onset. And then if in case that the clot is really present, or we are doubt of the presence of the clot, patient will be started on anticoagulant treatment. And then for thromboprophylactic therapy, currently we are practicing the chart vascol instead of chart score for risk stratification. Right, next we are discussing about the wide complex tachyarrhythmia. We divide into regular and irregular. So regular we have VT, SVT with aberrant conduction, SVT with bundle branch block. Irregular we have AF with aberrancy, AF with WPW, and polymorphic VT and Tosa Dipoa. This algorithm I took from the Shirley Oy also. All right. Assess the responsiveness, everything just like previous. slide. And then white complex tachycardia with pulse, stable, just started on electrical treatment. If stable or no symptom, we can start amiodarone and lidocaine. All right. Regarding the management of VT, according to Shallow textbook, they refer to Singapore guideline and also American Heart Association. There are two main drug option, whether amiodarone and lidocaine. But according to American Heart Association, they suggest to start procainamide and sotalol, which is more superior to lidocaine. But these two drugs should be avoided in prolonged QRS interval and heart failure. And then next, do not give more than one antiarrhythmic agent at one time. But apart from this, if all the medications fail, just we start the electrical synchronous cardio version. These are the doses. All right, this is the algorithm I take from the our CPG management of STEMI for edition 2019. All right, monomorphic polymorphic VT. So the management, we start monomorphic VT with amiodarone, and maybe we can repeat after that, and then if successful, proceed with oral amiodarone. If fail pharmacological cardioversion, we can just proceed with the electrical treatment. Right. So SVT with aberrancy, the management is just this short in textbook. Triad of adenosine may be given if SVT with aberrancy is strongly suspected. If in doubt or adenosine is unsuccessful, just treat patient SVT. All right, under the polymorphic VT, we and tosadipua, how to differentiate? From the QT interval, polymorphic VT is not prolonged, but in tosadipua, the QT interval is prolonged. And then they have different management. Polymorphic VT, we can start amiodarone, and tosadipua just start on magnesium sulfate. All right, this algorithm just like the same from previous. This one I took from ACLS provider handbook. This also just like the same, from triaging the patient, and then assess, do ECG, reassure whether to admit or to discharge the patient. But most of the cases, if the cardiac cause, we admit lah and refer to the medical team. These are the list of differential diagnosis of palpitation. Let's say patient presented to our ED, but show from the vital sign, investigation or normal, maybe we can still refer to the medical team for the ambulatory ECG or the Holter, or we can proceed with the formal echocardiography. All right, these are also the few differential diagnosis or the causes of palpitation, whether cardiac or non-cardiac cause. All right. Still remember the first case that I presented to you, 32-year-old female patient with complaint of palpitation. Palpitation were intermittent, and the patient is active in sport. He has no history of syncope or chest pain. She did not take any illicit drugs or smoke, and then no other chronic medical problem. Actually, from the case, recorded that her vital signs were normal. There was no jugular venous distension or pedal edema. Cardiac examination was unremarkable. The remainder of the physical examination also was normal. And then from the blood investigation, basic metabolic profile were within normal reference range. And ECG also revealed that normal sinus rhythm without ST-NT changes. So I will show you what are the findings from echocardiogram. So what do you see from this echo? All right. Any volunteer, or maybe you can type at the chat box. Any abnormality that you notice from the echo? Very nice, isn't it? Actually, this patient has 3 chamber of atrium. So right side of the atrium is one chamber, but her left atrium is divided into 2 chamber because of the congenital anomalies that patient has. She has a membrane in the left chamber, left atrial chamber. So the diagnosis is core-triatum sinistrum. Oh, tu dia. No. So
dia tu.
Tak tahu nak sebut macam ni. Core-triatum sinistrum. Itu dia. So basically, patient has 3 atrium. So the right one is normal, but the left atrium is divided into superior and inferior chamber. So only detected from the echocardiography. Alright. So in the end, patient underwent an uncomplicated surgical resection of the membrane. So some explanation, it is a very rare congenital malformation that occur about 0.4% of patients with congenital heart disease. So from the embryological process lah, dia punya anomalies happen, but the symptom only develop at the adult age. And then the management is definitive is the surgery if patient symptomatic lah. So this case was reported in American College of Cardiology in 2016. A very interesting case. Alright, in summary, do not downplay any patient complaint of palpitation, even if they appear well at the time of presentation. And then always repeatedly assess the hemodynamic status, because patient maybe initially has atrial tachycardia, but perhaps next time we assess the rhythm is changing. And always perform ECG as far as possible when a patient is still experiencing palpitation. And then if the ECG show a normal sinus rhythm, most patients warrant for an ambulatory ECG monitor or echocardiogram to look for any evidence of structural heart disease. And then reassess patients' hemodynamic status frequently. Although palpitation are benign, in vast majority of cases, they can occasionally be a manifestation of life-threatening disorder. A sudden onset of tachycardia in childhood or teenage years associated with breathlessness, dizziness, and chest pain suggests supraventricular tachycardia. Suspect a congenital anomaly. I think that's all for my presentation. I'm sorry for any shortcoming, and then I think that's all for now. I proceed with the approach to cardiac arrest. Shall we take 5 minutes for short break? Thank you.
Hello, good morning everyone. Can you hear me now? Can you hear? Okay. Okay, so I hope semua orang dah makan breakfast, boleh chill, relax. Because this is approach, I'll be presenting about approach to cardiac arrest. So cardiac arrest is part of our bread and butter. It should be part in our blood already by now. So I will not go through the normal algorithm of the cardiac arrest. So I will go a bit detail on what is the current latest evidence based on our approach to cardiac arrest. So if everyone ready, I'll start on. Okay, so we start off with our case study first. So if we remember our makcik Kia from last week punya Cme, our Tanyun punya makcik. So makcik Kia was discharged well last week. So she went shopping with Pakcik Asan lah. Pakcik Asan is a 72 years old male. Unknown case of HIHD lah. Developed sudden onset of chest pain. And subsequently he become unresponsive. So fortunately at the scene we have a Form 5 student. She's a female, so she had previously been taught CPR lesson by our ED team. So she immediately called for ambulance. So MECC received the call. So ambulance was dispatched to the scene. So, however, ambulance tak sampai-sampai because of Tekka the massive sale. So they stuck in the jam. So what should our next response going to be? So how the MECC going to instruct this Form 5 student to proceed with CPR? Should she, because this is a stranger, previously she was taught to perform CPR on a mannequin. So should she proceed with the mouth-to-mouth resuscitation on a stranger? So what does the evidence say based on the dispatcher's assistance in improving quality of cardiopulmonary resuscitation? So this trial was recently published last year in Singapore. So this trial actually divided to two groups. One group received the dispatch assistant, another group did not receive the dispatch assistant. So in this group, there are subgroup. One is a non-healthcare professional, one is healthcare professional. In the non-healthcare professional, they divide to subsequently to another two group. One group with valid CPR certification, while another group does not have any valid CPR certification. So what they see, right? So if you look at here, this is the rate of correct compression rate. So the rate of correct compression, even those without the CPR certification, the correct CPR compression rate was actually quite good, 32% in those with dispatch assistant. So what they do mean by dispatch assistant? So how they do actually this trial? So when this trial, they select participants randomly around the hospital in NUS, and then they ask the participant and they're given a phone, and then the instruction were given via the phone lah. So the phone was put at the side of the mannequin, and then they actually give instruction via the phone. So what the dialogue, the script of the dispatcher. So this dispatcher script actually been practicing in KKM, and I'm sure we have been practicing here as well. Of course, this dispatchers ada question ke? Okay. So dispatcher punya script ni we can actually translate to Malay or translate to our Kelantan Malay language also, not a problem. So we go back again. So why does the early compression needed? So we got few theories. One is the cardiac pump theory, thoracic pump theory, and also abdominal pump theory. If you have remember our first year that time in Kerry Brandis, so we got cardiac pump and also thoracic pump theory. So cardiac pump theory is direct compression of the heart between the spine and the sternum. So this will subsequently increase pressure in the ventricle at the closure of the mitral and transcatheter valve. So this subsequently leads to blood flow into your aorta and so pulmonary arteries. While thoracic pump theory is a theory that when you compression lead to increased pressure throughout the whole thoracic cavity. So this subsequently leads to a pressure gradient from the intrathoracic to the extrathoracic arteries. This abdominal pump theory, this one I found in Tintinelli. They say the abdomen, they got two lah. One is the arterial and also venous part. So the arterial compartment, the abdominal compression forces the blood from the abdominal aorta against a closed aortic valve. So this will go into the arterial system, while the venous component is where the blood return to the inferior vena cava. So now back to our patient. So this is a female Form 5 student. So she doesn't want to give a mouth-to-mouth ventilation for this patient. So what are the evidence based on hands-only CPR? So hands-only CPR is also known as cardiocerebral resuscitation. So they have actually proven that with hands-only CPR actually can improve the neurological survival of a patient. So what do they mean by neurological survival? If you read all these latest journal, they can keep on telling us what is neurological intact survival, what is it actually? So we got this scoring, cerebral performance category scoring system. So we got, this is the 5 scoring. So when it says good, that means CPC 1 and 2. What that mean by CPC 2? That means the patient is still able to walk, but minimal limb lah. Maksudnya still can actually shower, eat by himself, everything. So back to our patient. So now already this Form 5 student actually already started CPR for the patient, but because he's a stranger, she doesn't want to give a mouth-to-mouth ventilation, which is okay because we evidence said it's okay. So we can just continue compression first until help arrive. So when help arrive, unfortunately paramedic ni seorang je on the scene and with the ambulance driver. So ambulance driver ni, he doesn't know how to give a CPR. So should he, and we are quite good, this ambulance ada occupied sekali dengan Lucas. So should he use Lucas instead? So, is it better manual compression compared to your mechanical compression? So what does our evidence say? This is our Lucas here lah. So this meta-analysis was published last year. So they actually, if you remember, there's in terms of our mechanical compression kan, there are two types. One is your piston compression and also another piston punya type, and also another one is a load distributing band lah. So the piston type is our Lucas, which is compressing the chest up and down. So another one is the load distributing band is your autoplast lah. So we wrap around the chest. So if we short and lengthen, it should provide like a rhythmic compression. So what they, in this study, they look at the rate of the ROSC and also the rate of the good neurological outcome, the rate of hospital discharge lah. So they say there is no any significant difference between mechanical and manual chest compression, especially in patient with out of hospital cardiac arrest. So sama saja actually. So when do we actually use the mechanical CPR? So we use it when there is a limited provider availability, when we anticipate a prolonged CPR, for example, patient with hypothermic arrest or patient with lightning injury, or in a moving ambulance, which is much more easier, or in angiography suite, or maybe not available here in USM, the ECMO. So now this is the rhythm in the ambulance. So if we see from here, it's an asystole. So the paramedic call MSCC back and inform you the EP on the floor at that time and inform you what should you do next, because he's trying to get a line, try to give you adrenaline. So you inform, so you should give you epinephrine because already 4 minutes of CPR already. So what's the evidence base of epinephrine in OCA? So I think most of us know about the paramedic true trial, which was published in 2018. If you see here, right, it does say that epinephrine actually increase your ROSC, but it actually worsen your neurological outcome survival. So does it really good? Because now people are moving away epinephrine. So we always have to remember, in cardiac arrest, there's two main things: early high quality CPR and early defibrillation. So, okay, how about the dosage and when we should give actually our adrenaline? They said adrenaline, they said some studies, they compare the give 3 milligram, 5 milligram, is it better than the 1 milligram that we usually give? Or should we give much more in a shorter rate every 3 minutes, 2 minutes? So they come up with a study, they said that there's no significant difference between the time of first dose of with associated with any neurological outcome. But they suggest the dose of 1 milligram is sufficient enough because more than 5 milligram high dose of adrenaline does not show any significant outcome, the neurological outcome finding lah. So why does adrenaline people are moving away? Because as Bukhari have explained just now, but adrenaline has alpha and also beta. We don't want the beta effect actually, because beta effect increase your myocardial oxygen demand. So this is actually increase more stress to your heart. So we want the alpha effect actually for adrenaline, which improve the coronary perfusion and also increase the aortic diastolic pressure. So sekarang ni your MA cannot get enough, so he panic already. Should give you through ETT or should he try other thing? So we got IO in the ambulance, so he attempted IO. So this study also was just recently published as well. So they said, of course, definitely they said that in terms of IV, definitely far more superior than IO. Even our AHA still recommends your IV lah. But if let's say couldn't get line, a difficult line setting, we just still can proceed with IO. Okay. So now patients still stuck in jam. Jacker still having massive stay. Ada banyak kereta dekat sana. So patients still tak dapat sampai ke ED. So what should they do next? Should they intubate the patient? But this our paramedic ni, dia tak experience sangat. So should he actually try ETT or should he just put a back valve ventilate the patient, or should he actually put a supraglottic airway? So this is a systemic review that is done recently only last year. So they actually compare 78 observational study with 11 RCT lah. So what they actually, even ACLS guideline 2019 have adapted this lah. They said you still can use your back valve mask or advanced airway if let's say you could not intubate the patient and you find in a setting where low dia kata low how do you say that, kalau tak ada no training lah, if let's say this patient, those people who are not well trained, they still can use back valve mask. And also they suggest in OCA you still can use the supraglottic airway lah. Okay, so currently patients already red zone. So red zone, we know this is by heart. I think tak perlu explain this. I think all over asalnya ada yang sampai beratus-ratus patient dah tengok patient with cardiac arrest. So I think I'll skip this. So patient rhythm currently no pulse. So this is your VT. So what's your next move? This. So this patient was defib immediately. So post defib, this is his. So it's a F lah. Okay. So we proceed with next. So dah bagi defib dah 3 kali dah already defib already the patient but still persistent VF. So this will already term as refractory VF. So I'm sure many of you have heard this before, the double sequential external defibrillation, also the dose VF trial. This is the pilot randomized control trial was just recently published 2 months ago. So because previously all they only is just case report saja, no one actually did an RCT. Case report and cohort study and observation study. So this is the first RCT done 2 months ago was published. So what is actually double external defibrillation? So let's go back to our anatomy. Why we need to do this? Because as you remember, our left ventricle, the posterior structure is further away than our standard anterolateral electrode pads. So the posterior part tak sampai pun you nak shock the patient. So what they did in this study, they divide to 3 groups, which is one the standard, another one is the vector chain defibrillation, meaning they change from defib from the anterolateral to anterior posterior, and another one is a double sequential external defibrillator. That means they put 2 pairs on the patient. So there's 2 types actually, double sequential external defibrillator, another one is double simultaneously external defibrillators. So what hypothesis theory they come up with is like the more higher the energy, it improve the success rate. And also they say the first shock lowers the defibrillation threshold. So those increasing the second shocks, they perlukan lagi tinggi the joule actually. Okay, and then the third theory they come with multiple vector theory. So they put there more pads, more increase the vectors electricity to reach the myocardium. Okay. So this is the first pad. So your anterolateral and so anterior posterior. I'll show the video lah next. So in this study, they have memang significantly proven, if you see here, the ROSC ventricular, your VF termination is 82% patient vector change. That means you put anterior posterior. And also, if you see here, is that 76% those with double sequential external defibrillator compared to the standard. So how they do it? So let's look at the video. This is double simultaneously external defibrillator. Maksudnya, you put 2 pad and then you press the button at the same time. So this one has not been practiced, they didn't do in this trial because the manufacturer of the defib machine mentioned that they do not cover in warranty. And this will actually rosak nanti you punya defib machine. So let's start with the video. So how they do it first? Okay.
Yes.
So this is your third dah.
Start with compressions.
So this is your third shot they're going to give.
Both pads are going to be placed on the patient.
Okay, now only they're going to put in the second pad.
200
Okay.
joule settings, 1 operator, and we're going to shock the patient simultaneously. Yes, I have a crew member setting that up for me now. Excellent work, guys. 1 minute, 10 seconds until our next analysis.
Okay, so they put already the anterior pad. So with the next 32 cycle, they will roll over the patient. Okay, so now they're rolling over in the posterior.
Wonderful transition, guys.
Okay.
The application of DSAT or DSED is simple. The CPR accelerometer or CPR puck is removed. The anterior pad is applied. Puck is then reapplied on top of the anterior pad. The patient is rolled over and the posterior pad is applied. You will notice that interruptions in CPR are minimized throughout this procedure.
Yes,
So-
we've got both EFibs, dual to 200. Both sets of pads have been placed on the patient. Excellent CPR. Our next analysis is less than 30 seconds. So 10 seconds until our next analysis. One operator, please. Ventricular fibrillation is being seen on both monitors.
So you see? So they shock at the same time.
Excellent, thank you. Let's switch.
All right. So let's look at next. Okay. So this is double simultaneously external defibrillation. So yang ini can look what's the difference. This is double sequential.
After your third shock has been delivered, prepare the second X series for double sequential. Third shock delivered. Now double sequential study. After 30 impressions into ventilation, apply the posterior fusion pad as the second monitor during the first compression process. Remember to remove the pressure sensor. Apply the anterior fusion pad of the second compression process. Complete the full 2-minute CPR cycle. Analyze the patient is still in VF. CPR. Monitors 200. CPR. Shock 1, shock 2.
Okay, you see here they shock 1, shock 2. So dia tak tekan sekali. After like few second delay baru they press the button for the to shock the patient. Okay, yeah. So next is the vector lah. See vector ni just to change the pad. If you see how they transition, they use the lateral posterior.
Patient still in VF, back on the chest, we're charging. Legs charge 200, everything hands off. Shock delivered, back on the chest. After 30 compressions, 2 breaths.
So they put on the posterior pad. So kan dia pasang sana tu lain tu, but tak boleh connect the same dengan. Yeah. Itu kat posterior vector change.
our fourth rhythm analysis. Yeah, continue CPR, chart into 200. Stop CPR, everybody hands off. Shock, continue CPR.
Okay. So another one more actually beta blocker is refractory VF because now we have beta effect. So there's some study they say they give esmolol for those because it is very selective to beta 1. But AHA did not recommend yet lah this esmolol usage in refractory VF. So now back to our patient. So after 60 minutes of resuscitation, so what's our next move for this patient? So the pulse is still asystole. So should we continue CPR or is there any role for this patient? So we have been practicing focus in ED. So what are the advantages? So one, be able to identify any reversible causes. So we can look for any cardiac tamponade, pneumothorax, pulmonary embolism, hypovolemia. Definitely we can use our VBG and also FBC to look for any reversible causes as well. So ultrasound also we can use to confirm our ETT placement. But it is also a good prognostication tool because absent of cardiac activity associated with poor outcome. In those of us have studied before the recent trial, which said that they concluded that in the cardiac activity which is absent in the first 5 minutes of CPR, then it associated with poor outcome. But the disadvantages of ultrasound one, you can possibility of double the pulse checks. And so it can be challenging in patient with subcutaneous air from traumatic compression. So for example, like 2 days ago, we had 11 years old boy with massive bilateral pneumothorax. It was very difficult actually to actually get a good echo or to do a EFAS for the patient because of the this air. We want to actually integrate our ultrasound in our cardiac arrest. So this algorithm actually ada this one. So if let's say patient with PEA, so this our patient jadi the asystole, there is no pulse. So we look at the rhythm there, whether is the ECG rhythm dia narrow ke wide. So if the narrow, we do an ultrasound. So we look at the ultrasound, we look at the RV dia, we look at LV full, whether hyperdynamic. Then we look at the RV, whether RV collapse or RV full. So we look if it's full, then we know it's PE, we can thrombose the patient. So if let's say RV they collapse, it can be possible tension pneumothorax or cardiac tamponade. So we treat accordingly lah. Cardiac tamponade, we do pericardial synthesis. Tension pneumothorax, we can do needle compression. And if let's say the QRS you nampak PA dia macam wide, then it can be, then look the echo, tengok LV dia hyperkinetic, it can be due to hyperkalemia or sodium channel blocker, we can treat accordingly. So if hyperkalemia, give calcium chloride, sodium channel blocker, we can give sodium bicarb lah. But there is a downside about this wide QRS is, for example, if patient yang ada aberrancy or the patient with PE with RBBB, so they can still present with wide QRS. So we always should correlate with patient punya history and also physical examination. Notice everything kita buat, bila dapat patient cardiac arrest, pass ada ke, pass tak ada ke, is it true ada pass ke, tak ada pass ke. So they actually did a study actually comparing your cardiac ultrasound, the Doppler and so manual pass palpation. So what they compare the manual pass palpation, they did a Doppler, the Doppler one they did dekat left femoral. So the cardiac ultrasound they did subxiphoid view lah. So compare all these three methods, cardiac ultrasound is memang more accurate and is the paling cepat, within 4 seconds they can do it. Compared to pulse check it is 10 seconds. And also the false negative in pulse check. Like for example, a patient with hypovolemia, the patient might be got PA tapi rasa the pulse. So when they did an echo, they actually can see there is cardiac activity. So the best way is actually now we are going into a cardiac ultrasound now. So we decide to terminate resuscitation. First, of course, once we dapat ROSC, patient memang already very bad pre-existing comorbid, for example, those with malignancy, with meds, or acute illness, the preventive recovery, for example, those patients with burn, 100% burn, or patient in following 80 minutes, then dia punya with efficient resuscitation, there is no point of us continue lah because the outcome is poor. So how about in pre-hospital? So when do our paramedic actually stop CPR. So when of course when there's no ROSC, when no shock will deliver, when dia datang pun memang tak perlu any shock, when the arrest is not witnessed. There's special situation like for example in newborn baby we know detectable heart rate and we see the undetectable heart rate up to 10 minutes we can stop. Traumatic arrest if let's say we don't do this lah, I mean kat sini thoracotomy bedside we don't do ya. So or when the rescue is actually exhausted, so patient memang dah confirm dead lah, dah rigor mortis dah, then tak perlu lah. So when not to stop CPR, okay, young patient with persistent VF, okay, we need to treat the reversible factor first. Hypothermia patient, asthma, we need to correct the dynamic hyperinflection. Toxicology arrest, especially those patients, some will still recover even after 4 hours of CPR. Patient who are thrombolytics given during CPR should continue up to 2 hours. And patient with pregnancy should continue prior to resuscitative cesarean section. This one I think previously Charlie team have presented COVID punya time during cardiac. I'll just go through ni. So if let's say someone call you, oh this is the COVID, possible COVID patient, so already arrested, we still actually can cover the patient face, and also we can cover our own using a face mask, then still can continue our hands only CPR. So this one also I'm sure all of us have gone through it before during our SARI team as well. Okay. So our take home message is first, early CPR is beneficial. Our lay rescuers still can provide CPR. So mechanical CPR still have a role in OCA. Also, and also early dosing and so lower dosing have epinephrine epinephrine have to improve survival. IV definitely better than our IO. We still can use supraglottic airway in our OCA, and also double sequential external defibrillator for refractory VF. Maybe we can try it here. Personally, I've done it only twice with 50% successful rate ROSC one patient, but then even the patient the ROSC eventually passed away in ICU. Can use incorporate focus in cardiac arrest. So that's all. Thank you. Got any question?
Hello. Hello. Okay. So the second question, which among these is false regarding atropine? A causes paradoxical bradycardia. B crosses the blood-brain barrier. Is a non-competitive acetylcholine receptor antagonist. Is hallucinogenic. So the answer is C, as mentioned by Bukhari earlier in his slides. Atropine is a competitive acetylcholine receptor antagonist. So, okay. So as you all know, it's an anti-muscarinic action. So competitive means if there is, you compete with the agonist, which is the acetylcholine for your place in the receptor. So if there's more acetylcholine, you will be displaced and acetylcholine wins. So that's what it means by competitive antagonism. Okay. Atropine does cause paradoxical bradycardia. This is because in low doses, atropine acts on M1. In slightly higher doses, it acts on the heart. So there's this reflex, which I'm sure we all know is the basal-gyrus reflex associated with this. The drug, yes, it crosses the blood-brain barrier and it also crosses the placenta. Due to this, the ability to cross blood-brain barrier, it can lead to some CNS excitation and can cause agitation. It's hallucinogenic, some amnesia, delirium. Okay, the third question, lidocaine can be used as an alternative to amiodarone in cardiac arrest from VF or pulseless VT. Which of the following statements regarding lidocaine is false? So A, lidocaine blocks permeability of neural membranes to sodium ions is correct. If no IV or IO access available, the dose for ET administration is 2 to 4 mg per kilo. It's also correct. The initial dose is 0.5 to 7.75 mg per kilo IV/IO over 5 to 10 minutes is wrong. It's not the correct answer. The correct answer is the initial dose is 1 to 1.5 mg per kilo IV/IO in cardiac arrest from VF and pulses VT. D is correct. Lidocaine classified as a 1B agent. Okay. So as you can see from this diagram, the initial dose for cardiac arrest from VF and pulseless VT is 1 to 1.5 mg per kilo. Question 4, the correct dose for epinephrine given in the bradycardia algorithm is 2 to 10 mic per minute infusion. Okay. Okay. Question 5, a 30-year-old lady presented to ED complaining of palpitation. Her heart rate was 178 and is hemodynamically stable. You perform wiggle maneuvers but was unsuccessful. You decided to give IV adenosine, which regarding adverse effect of adenosine is not true. So it causes bronchospasm, asystole, facial flushing. It doesn't cause thrombocytosis. So this is a chart from Medscape. They divide the occurrence of side effects based on the percentage of occurring. So as you can see, more than 10% patients suffer from flushing and dyspnea. Whereas you do get bronchospasm, but it's not, the percentage is not well defined. You get cytosis from adenosine. Question 6, if the initial shock terminates VF, but it recurs again later in resuscitation, so A, deliver subsequent shocks at maximum energy dose. B, deliver subsequent shocks at the previously successful energy level. Do not deliver any subsequent shocks and continue CPR. D, begin cardioversion. The answer is you deliver subsequent shocks at previously successful energy level. Okay. All right. Question 7, epinephrine is used during resuscitation. A, because it causes vasoconstriction. B, to stop allergic reactions causing heart failure. As a pain reliever for the victim. D, because it is an anti-arrhythmic. So the answer is A, because it causes vasoconstriction. From what our colleagues presented earlier, we want the alpha action of epinephrine. Okay, so like it says, it's used during the primary for its, it's a mistake here. It's primarily for its adrenergic effect. Alpha, sorry, it's a mistake. Vasoconstriction, thus increasing BP and heart rate, improving perfusion pressure to brain and heart. Sorry for the mistake there. Okay, question 8, you give amiodarone 300 mg first dose and finish the cycle of CPR for a patient. Upon rhythm check, you see the patient has converted to normal sinus rhythm and has a pulse. As you begin the post-arrest care, patient has a short run of VT. in light of continued arrhythmia, you start an amiodarone drip for maintenance therapy. What is the maximum cumulative dose for amiodarone in a 24-hour period? A 2.4, B 1.5, C 2.2, and D 5 grams. So the answer is 2.2 grams within 24 hours period. Okay, sorry. Okay, so this is from the AHA ACLS guideline. For life-threatening arrhythmias, maximum cumulative dose of amiodarone is 2.2 gram IV over 24 hours. Okay. Okay. Question 9. AV nodal blocking agent should be avoided in patients with AF with pre-excitations. In our 2014 ACC AHA guidelines, they already mentioned as when AF presents with pre-excitation, all the is considered harmful for the patient, okay, because it can cause a paradoxical tachycardia if given in these patients. Okay, question 10, what is not a precaution to transcutaneous spacing? TCP is contraindicated in severe hypothermia and is not recommended for asystole. B, conscious patient require analgesia for discomfort unless delay for sedation will contribute to deterioration. C, avoid AV nodal blocking agents. D, do not assess the carotid pulse to confirm mechanical capture. So the answer, which is not a precaution, is C, avoid AV nodal blocking agents. It has no whatsoever relation. We do not assess the carotid pulse to confirm mechanical capture because this electrical stimulation may cause muscular jerking that may mimic the carotid pulse. So these are the precautions for TCP normally follow. Okay, all of the following statements are true regarding the arrhythmia shown above, except A, prolonged repolarization period gives rise to delayed after depolarization. B, TOSAT is initiated when a PVC occurs during the preceding T wave known as R on T phenomenon. C, treatment includes IV Maxalv, 1 to 2 gram. D, hypokalemia could be a cause. So everything is true except A. It causes after depolarization, but it causes early after depolarization and not delayed after depolarization. So earlier in our lectures, our first presenter mentioned about after depolarization. Basically, it's just anything that interrupts your normal action potential in your cardiac action potential. Any depolarization that occurs in phase 2, phase 3, phase 4, or after phase 4, it's called after depolarization. And all this is caused, the culprit is our ionic changes or ionic channels. So any change in that can lead to after depolarization. But this TOSAT is caused by early after depolarization and not delayed after depolarization. Example for delayed after depolarization is our digoxin toxicity, where there's increased after the phase 4. Okay. So this is what I meant by early after depolarization. There is some trigger at phase 2, phase 3, which can give rise to a trigger during these phases, and later on will lead to VF. Okay. Okay. This is an example of DAD, which occurs in digox toxicity, where you see it goes through a normal action potential, and after the phase 4, while before another action potential is formed, there is a trigger after your phase 4. So that's a delayed after depolarization, which occurs in digox toxicity. Okay, this is the R on T phenomenon, where there is an ectopic beat superimposed on the T wave of a preceding beat. Okay, so a serial R on T pattern can trigger the tossat to occur. Okay, so tossat TDP can be caused by the following drugs except A. Amiodarone, B. Procainamide, C. Lithium, D. Pseudoephedrine. The answer is D. The rest of the drugs can cause a TDP. You may notice this quiz, there's a lot of questions on drugs because a lot of drugs comes out in MCQ, our part 1 MCQs. So there are a lot of mnemonics and mnemonics to remember these drugs. So you can choose whichever that you prefer. So question 13, what are the two most common causes of PEA? The answer is hypovolemia and hypoxia. So whenever patient comes, we should look very thoroughly for these two because this is, it's reversible and it's the most common. So you should look and try to correct it. Okay, endpoints for the administration of procainamide infusion for stable white QRS tachycardia includes this basically is just asking when do you actually stop the infusion? What are the endpoints of if you give procainamide in stable QRS tachycardia? So A, hypotension, B, 50 to 100 mg per minute until arrhythmia is suppressed, C, maximum dose of 7 mg per kilo is reached, D, increase in heart rate by 30 points. The answer is A. We are all very familiar with this algorithm, but sometimes we overlook the small part of where some extra drugs are. So sometimes it's good to know all this. So procainamide, if you read this column, it says 20 to 50 mg per minute until arrhythmia is suppressed. So our question was 50 to 100 wrong. Or hypertension ensues. QRS percent or maximum dose of 17 mg per kilo, not 7. Okay. Which of the following drugs can be administered via ETT? So the answer is lidocaine and epinephrine. There's a mnemonic for this, well-known mnemonic. So the drugs that can be delivered via ETT is naval. We remember as naval, naloxone, atropine, vasopressin, epinephrine, lidocaine. The last question, what is the correct energy dose for unstable AFib when delivering monophasic synchronous shock? So biphasic we know is a 120 to 200, monophasic is a 200 joules. So this is the end of my slides. So Anum, would you like to add on?
Summary.
Thank you to all the presenters for such an amazing presentation. We hope our sharing for today will our presentation today will somehow make a good revision and split more sharings in the future. So we would like to know, can number one, our winner VT and quizrobot.com and Sleepyhead, please introduce yourself in the group. The first two je kan? Bukan nombor tiga kan? Sorry. We only prepare for the first two winners. So the lucky winners are VT and also quiz.com robot. So can you please show yourself and
the place can buy a prize for themselves.
okay. All right, and I hope this sharing and discussion will stimulate further discussion. If there is any problem or anything that we are unclear of, you can always approach in the group. And if we don't know the answer, we will go to our specialist. Okay. Itulah. Siapa ya VT dengan quiz.com? Can you show up your hand or comment in the comment section?
PM lah, PM.
PM pun tak apa kalau malu. Okay. Alright. So above all, we discussed about adult approach of tachy and bradyarrhythmia today. But in children, maybe the causative agents and the approach is slightly different, but it's of another topic in the future perhaps. And thank you for all your attention. Sorry for any shortcomings. And see you in the future. Okay, bye.